Okay.
Call to order our March 24th, 2026 Finance Committee meeting. May I have a roll call, please?
Yes. Ray Peterson? Yes. Jessica Dixon? And Mike Russell?
Yes.
Director Gallagher?
Yes.
And Chair Pimentel?
Yes. Do you have any changes to the agenda? Great, thank you. Let's move on to public comment. The time for matters not on today's agenda time will be set aside for any members of the public to address the committee on any item not on the agenda and not to exceed 2 minutes, which is within the subject matter jurisdiction of this committee. Comments regarding items included on the agenda will be heard before the item is discussed by the committee. No action or discussion shall be taken on any item presented except that any committee member may respond to statements made or questions asked. All matters of administrative nature will be referred to staff. Pause there and see if there are any questions or anybody wishing to speak during our public comment.
No hands online.
Any comments here? Great, let's move on to comments from committee members. This is just an opportunity for committee members to provide any other updates not on today's agenda. And let's move on to consent. On our consent agenda, we have one item. These are minutes from our February 24th, 2026. Submitted for approval. They were included in the packet that went out on Friday. I'll entertain a motion to approve consent or to take action on consent. Second. Thank you, Jessica. Seconded by Joe. Dr. Gallagher.
I'll take roll on this item. Ray Peterson? Yes. Jessica Dixon? Yes. Mike Russell?
Yes.
Director Gallagher?
Yes.
And Chair Pimentel?
Yes. Let's move on to item number 2 of our 4 discussion items today. The second item is financial performance for the month of February 2020. I just know I appreciate having you're always looking to add new value to us so that we have a narrative. So thank you for having that narrative that helps explain the details of what's going on behind the scenes. It's really appreciated.
You're very welcome. All right, very good. Well, I am pleased to report that in the month of February, we had a favorable month. We actually exceeded our budget with a net income of under $250,000. It was a month where we had budgeted a $922,000 loss, so that was a favorable $1.2 million month. Probably the largest variances from the month-to-date perspective relate to Clock 9 not being approved. The fact that when we did build our budget, we built in some receipts from Clock 9 to come in early in the month or early in the year, as well as some expenses. So the receipts would have shown up in the net operating revenue amounts. So we're favorable even without that, but would have been more favorable in net revenue. And the expenses would have shown up in the other line, and that is explains some of our favorability in the other line. Next slide. On the year-to-date, by having a good month in February, we were actually able to come back into the black for the year because we had an unfavorable month in January, but it was strong enough in February that we're now posting about a $91,000 bottom line year-to-date. And really the largest variances again relate to the QAF payments and receipts. And as you'll see, our volumes this year are much closer than they were last year, and so that is just kind of helped tightening that net revenue variance that we've seen.
Block 9 9, deciding some context around that, I think would be really helpful in this moment. COP 8 was valued at around $16 million, and COP 9 we were expecting a similar.
Well, when we had built the budget for QOP 9, it was still at the point in time where the QOP 9 program was expected to be larger.
Yep.
Now, we had taken what we thought was a conservative approach at that point and budgeted 75% of that program. Since then, QOP 9 has been at the state level being revamped per CMS guidance that it wasn't going to be approved as such a large program and that it was likely to be approved closer to a QOP 8 program, which means that our 75% would still be over budgeted for QOP 9. We did net last year around $16.5 million. So if QOP 8 is approved somewhere in that range, that is what we would expect. That would have a $2 or $3 million impact to us from what we had budgeted. The one thing about QOP 9 is there's the approval of the program size, and then there's another set of negotiations that goes on at the state with how it's structured. And so there may be some structural changes to the program that just have it pay out a little bit differently than what we saw in QOP 8. That's still the...
I guess the main takeaway there is QOP 9 cash that should have already been in our books under a normal functioning system where the federal government would have partnered with the state and already arrived at a decision.
Yes.
Approved QOP 9, it would already be cash flowing in, maybe even last fall, with small amounts.
No, correct. You're absolutely right there in that typically these programs, the state submits them by March 31st of the prior year. So submitted their original program in March of 25. It's usually approved sometime in the summer and implemented by the fourth quarter of the year. So we're a year behind in the approval, still waiting for an approval, and then from that point, waiting for when we start to make payments. And that's likely won't see that before close to the fourth quarter. So that delay has been detrimental to our cash flow.
Yeah. No, I don't mean to make it light, but I appreciate the context. It's a big moment of something that the federal government has done without necessarily national notice or congressional discussion. An administrative decision that's held us for almost a year. Thank you. To the next slide.
So here's our month-to-date statistics, and you can see that we actually had a fairly strong month with admissions at 283 admissions, and that put our average daily census at 31.1, which is two more patients per day than we had budgeted for. We had a little bit lower length of stay, so our patient days are a little tighter than the admission volume variance, but again, the length of stay being lower somewhat jives with our case mix being a bit lower than what we had budgeted. Deliveries were not quite as strong as budgeted, but 65, especially for a 28-day month, is pretty reasonable. We did exceed our inpatient surgeries volume budget by 6. We were short on outpatient by 15. Our one area where we're still falling short to budget is in non-emergency room outpatient visits, which encompasses many things. It can be labs, radiology. It is inclusive of outpatient surgeries. So there are a number of things that can fall into that category: wound care visits, rehab visits, and many of those have some lower volumes than planned. Our ER visits, they were up a bit, so slightly over budget, with 32 planned, and we were running 90 visits a day for the month. And observation cases slightly below budget. We did have our MRI services become available halfway through the month, so that was some good news for us after about 4 months of MRI. And category, slightly ahead in admissions, ahead about 1 per day in census, and the length of stay being slightly lower, along with the case mix slightly lower than planned. We are, within 6% of our surgery budgets, both on the inpatient and outpatient side, and it's really in the outpatient business where we are seeing the largest variance. And the ER visits for the 2-month period is 89 per day. So that's just slightly. So we put all this in kind of a case mix adjusted context just to really try to understand from a volume and acuity mix, how are we doing against how we planned our budget. And probably the things that stick out the most, thinking about this in the context of this calculation, we have a lower case mix than we budgeted, but we had more discharges, so we, on a case mix adjusted discharge, a slightly larger number, with 28 more adjusted, CMI adjusted discharges to spread expenses over. And really the plant utilities, category here, which includes utilities, repairs and maintenance, taxes and insurance, was the one area that was unfavorable for the month of February. And this was actually in the insurance category within there, and has to do with some postings that are some catch-up postings that cover multiple months of insurance payment. So nothing too worrisome there. You can see most of the time where our actual expense per CMI adjusted discharge is less than what we planned for. So there's some good work being done to manage expenses. So the year-to-date is really pretty much the same story. The largest piece here, the overall or total operating expense, and the overall kind of other expense, where we see some of our favorability, has to do with the fact that we don't have those QAF 9 payments. So going into a little deeper into some of the metrics, here's our inpatient volume. You can see that the admissions have grown for the last 4 months, starting back from November on up. And our length of stay has stayed, fairly constant and lower here in February. Also lower case. Deliveries, kind of right on par, 65 is kind of middle of the road for us. We did have 15 NICU admissions in February. On the ER visits, as I mentioned before, 90 visits per day. We have that increasing trend over the last, certainly more than the last 3 months, about the last 5 months. And we did convert 7.5%, or 189 admissions came from the emergency room. But, on the outpatient side, here I mentioned before, we didn't have any MRI services in October. We haven't had any HBO services since August. And then we had lower volumes in our outpatient surgeries, our physical therapy visits, and some of our imaging modalities. Here's the inpatient surgical cases. The top 3 kind of continue to be the top 3, so OB/GYN, general surgery, and GI. And one of the things that was noticeable this month is that it was a fairly high government payer mix. On the outpatient side, it's the same thing. We don't see a lot of variety in other modalities taking over the top spots, but we're fairly constant in more. General surgeries were down a bit. It was about 15% general surgeries this last month. OBGYN just within 3. This is pretty close. We did, I think that says 22 robot-assisted cases. Okay. So, next slide. From a payer mix, the good news is that we rebounded in our commercial mix. Last month had been a low commercial mix at 13. That was one of the lower months. Back up at 20.8, which is one of our higher months commercial. And where we've seen probably the most decline, we saw it's actually a little bit spread out here in all of the other categories. I'd say that the Medicare and the Medicare kind of took the brunt of it, but you could see a little bit of decline in managed Medicare. From the outpatient side, as I think I say almost every month, is pretty consistent. Up a little bit in the Alliance managed Medi-Cal category this month, and down a bit in commercial, but fairly constant as it has been for as long as I can remember.
I think we've had the conversation about outpatient and the pennies on the dollar reimbursement rate we get from Medi-Cal. So when we have lower months of commercial pay, that is, we're losing not only volume, but we're losing the value, the reimbursement value.
Yes, correct. Government payers, especially in the outpatient space, is significant. I think that is my last slide.
More maybe conjecture and observations. So I mean, good month for sure. Glad to see that it's a structural rebound with based on volumes versus adjustments or anything else. So that's promising. It's interesting to see the trend of visits. Just going back to like inpatient volumes. Ironically, in July of 2025, this kind of dropped off the cliff and hovered, reasonably low, and now starting to come back. And I hope it's a reflection. I mean, it pains me to think that people chose not to get care during that time period, but they need care.
I think there's potentially some probably initial fears, but I think what I've heard is there's been some illnesses in the community.
Yeah.
And so I think that there's
ER visits coming up.
Yeah. So I think there have definitely been some illnesses that have brought people here whether they wanted to be here or not.
Especially on I've gotten sort of fascinated that we have a 7.5% conversion rate from the ER visit to admission. Do we know if we have a large number of people who have low-grade illness, or a combination of that and a lot of outpatient management, more complicated?
I don't have a lot of specifics on the current ER mix. We're actually trying to develop some reporting so we can look at it by ER levels.
Sure.
And, historically, I've heard that, we tend to kind of be middle of the road a little bit, maybe on the lower acuity side, which would be reflective in admissions and in our overall case mix once they're admitted.
Sure.
But we are trying to develop some reporting so that we could understand that piece a little bit better.
Do the ER docs, when they code their own stuff, that's coded at a level, or is ours also like?
The hospital has acuity levels for coding, the acuity and billing charge levels that go along with that.
The other one's an operational question. I had heard at some point, mid-February, we got the MRI back online, and then somewhere within a couple of weeks, it was down for a major service or some such.
I don't have any details on that.
I'll ask it.
Observation. drives for balance sheet transactions. And cash have a stronger month in February, but still at a level that we should still measure it in days of cash on hand, not months. Well, I'm glad to see some recovery. We still have a chronic problem with largely, what would our cash balance look if the answer portion of that 16 million-ish of Quoff 9 were here? And we wouldn't carry AP balances. So.
Yeah, so I think the answer to that is that our cash balance would not, some of this is just the timing of when we got our last advance and when payments have gone out. And if we had gotten the Quoff 9, the cash balance would still be low because we would have paid down more of the AP. Yeah, so we're still living in a very low days cash on hand.
Not too far off. Started 2022. Was there anything that I commented about February being what appears to be largely a structural positive month? Was there anything in looking deeper into the finances that anything that would be an anomaly or one-time element in there? I mean, we see final advance in Clause 8. Do we have any more advances eligible on Clause 8?
No, we have a few residual dollars that'll come in. Some should come in month or early April, and then in October, but those are minimal residual dollars. We do still have expenses to pay for those dollars that we've negotiated with the state. No, I think I try usually in my PowerPoints to call out the anomalies or the most significant items for discussion. And I did, as you mentioned, try to put a little bit more narrative together, just around the various categories and what we're seeing.
Have any other questions at this moment? Again, I appreciate the work all the mighty team is doing and presenting our monthly financials both to the hospital and the district in the consolidated fashion. Good month. Any other comments from committee members? Questions? All right. No action is required. This is just a accept and receive, and this will be moving on to the board discussion for tomorrow. Second item is our Power Valley Healthcare District and Power Valley Healthcare District Hospital consolidated audit report.
At this point, I would like to introduce Gerald Tucker to the group to speak to us about the audit. You have met Gerald in past years of audit, so I will let him take over.
Okay, thank you for that. Everyone hear me okay?
Yeah.
Okay, do we have any new members on the Finance Committee this year?
We do. We have Mike Russell, who's our Revenue Cycle Director. He joined us in July of 2025, and he was elected to our committee when Matco left.
Okay. So let me make a note of that. Well, I just say that because I try to be make as much explanation as possible, but without going over things that we've gone over in the past years and whatnot. So Mike is new, huh? Okay. So Mike, but luckily, Mike, you're in the revenue cycle part of things, so you already understand probably one of the most confusing and technical part of healthcare accounting, which is the whole revenue cycle, the billing and the contractual allowances, bad debt, and so on and so forth. So that'll be certainly a step in the right direction. Okay, let's get started here. This is the audit just ended this past year, 12/31/25. And what I'll do as in prior years, I'll go through the four, four main items, or the four items that are required to be reported by the auditor to the board. So kind of screen them with you first, go through it, let you ask any questions, and hopefully come out of this meeting with the committee, uh, basically approving or recommending to the full board that the audit be approved. And so that's kind of the um, hopefully hopeful result of this meeting. So the things I have to present to the board, and well, I'll go through with you first. First off, talk about the opinions that you receive. So there's actually there's two audits that are being done, a normal financial audit, which is a consolidated audit of the healthcare district and the community hospital and the what is that called, physicians group, or whatever whatever you want to call that one. Um, let's see that. Oh, they're part of the district anyway. So, okay, so the district and the hospital are combined or consolidated for each year, and we do two audits. Um, we do the financial audit, which is the district and the hospital. We also do a governmental audit, which is on the district because the district's considered a governmental entity, and so there's some heightened work and another report needed for that. Both reports, both for the financial and the governmental audit, received a clean opinion, an unmodified opinion. I would, you have access to the actual draft of the financial statements, everyone there at the meeting?
Yes. Yeah.
So if you go to page 1, the first numbered page in the draft audit, it's the opinion report of independent auditors. And if you go down, the second to last paragraph is substantial doubt about the entity's ability to continue as a going concern. So this was added this year. It doesn't change a clean opinion. In other words, the opinion is the numbers are good. I mean, the numbers are accurate. There are no material issues or being different from GAAP or anything like that. But what this basically says is, based on what we know right now, current point in time of the hospital's financial situation, there's some doubt that they could continue another 12 months if things didn't change significantly. And then I'll get into that a little bit later, but I wanted to make sure you understood that you're getting what's called a going concern paragraph in the report. And I don't know if you've discussed that before, if most of you know what that is or not. But if you have any questions about that, I'd be happy to answer or explain it a little bit more. Any questions about that substantial doubt about the going concern?
No, not for me.
Okay. All right. Well, then we'll continue on. I mean, I think it's pretty obvious. I mean, the staff does a great job of Jessica and her staff and whatnot, and do a great job of making sure that everyone knows, kind of what's going on here, and so there's no big surprises there, I don't think. There were no material weaknesses or significant deficiencies identified relating to the district's internal controls, and there were no reportable findings. So as we go through, both for the financial and more so for the governmental audit, any errors, any issues, reporting errors, and so on and so forth, have to be brought to the board's attention. There was nothing of that nature during the audit. The third point is, there were no quote unquote audit adjustments, but there were various late client entries. We start the audit pretty early. I mean, we're reporting on this audit, in March, at the end of March, which is a quick turnaround for an audit of this type and this size. And so we get the audit started, and there's still some work being done, by the staff there, and trying to figure out, what all, for the close and so on and so forth. So they want to make sure that, uh, everything's we can get started and work on a lot of things first, but then, we can continue. And then if, as they find issues or uh, continue to do reconciliations, we'll go over those entries and we'll book those as late client entries. Overall, there was just a handful of entries. There was cost reports being cleaned up, which is very normal. There was some pension and workers' comp and other payroll related liabilities and whatnot that were cleaned up, and that's kind of between the various companies, and so that's been common. There was a late bill that came in for some professional fees from a doctor, and same with from CareFusion, some equipment charges and whatnot, and then some bond entries that I'll talk about in a little bit here. But those all were worked on after the audit started, got them booked. Overall impact was about an increase of about $1 million to income for the adjustments. And then lastly, the fourth one is there are no difficulties encountered with management in performing the audit, no disputes, no disagreements. They do a great job of providing us everything we need. We get all the information we need. We get anything we ask for is provided quickly, and there are no limitations put on us at all to holding us, limiting what we audited or what we saw. So everything was provided. So those are the four things we have to report on to the board. Any questions on those four items?
No question.
You guys are good? Okay. So let's just talk about a couple of significant accounting issues this year. First off, again, I talked about that with the component unit reporting. The district and the hospital have to be combined. They're considered component units, and there are specific directions for that. And we've done that in the past. So you've got the consolidated, so that even though the district is a governmental agency and the hospital is a nonprofit, they're still kind of they're connected based on component unit reporting. You'll notice this last year we had the general obligation bonds were issued, and this year we started having scheduled payments, interest was paid and whatnot. And you'll also notice this year for the first time you had district tax revenue, significant district tax revenue was recognized with the GO bonds, the general obligation bonds, as the county now, which they have done their first set of billing, as they bill and collect money on your behalf, and then spend that money to pay the debt service. The amount that's paid on debt service, accrued and or paid, becomes district tax revenue through this process. And so you'll notice you had about $3 million in district tax revenue, which was associated with the debt service on those bonds. And so all the payments were made timely and whatnot. A little bit of couple hiccups there on the timing, just kind of getting the county up to speed on what needs to be done and how they pay it and whatnot. But all in all, you were in compliance with everything that needed to be done for the general obligation bonds and the trustees for those bonds. And so we make sure those are all accounted for properly, and that's a big item in the audit. Last year was the purchase of the hospital, which was a big thing, and that's been done. So this year, fixed asset purchases was about 1.8 million, just kind of in the normal course of business. Can we look at those as well? No other new significant debt or whatever, no other issues or red flags that we came across from making sure the numbers are accurate or reported properly. But as I said, we do have the going concern issue. Cash is tight. It's good news to see how the year has started out. I also have January and February's financials, and it looks like it's kind of turned around. As a matter of fact, a significant turnaround where you're at break even, or actually made a little bit in the first couple of months of the year. And so that's going to be necessary to keep the hospital moving along. You can you can be a no profit, a nonprofit. Hospital's a nonprofit. The government's a governmental agency, which is considered, similar to a nonprofit. But the bottom line is you've got to have positive operational outcomes on an ongoing basis, and limit the losses and whatnot, or you just eventually, whether you're a nonprofit or not, you run out of money, and it's difficult to run an organization without any funds. So that's probably the biggest concern right now. Everything else, there were no other surprises or huge red flags other than that, just the operational issues, results of operations that required that going concern um, uh, paragraph there. Okay, any questions on any of those issues there?
No.
Everyone comfortable with this?
Yes.
Okay. Want me to cover anything else, Jessica? Anything? I'm sure you've probably talked most of this stuff, most of the stuff to death. You guys do a pretty thorough job. I just heard your presentation. It's a very thorough and straightforward presentation. So I don't think there's any surprises or anything I would bring to the table for a couple of months ago at the end of the year.
I do have a question now.
Yeah.
Gerald, is
Yeah.
this the same concern, the ongoing enterprise, or whatever the phrase is, substantial doubt about it? Is this the same level as we got on the prior audit? There was a similar comment last year.
Let's see. I thought we added it. I thought we had it, got rid of it, and then brought it back.
I think we had it last year, because even though we had a favorable year financially in '24, right around break even, a lot of the headwinds,
Sure.
things that
Oh, yeah.
we document in the manager discussion analysis, we're still out there.
My concern is at some point I learned that there are really 4 levels of these, and I just want to make sure we're still at the lowest level.
Yeah.
Okay, thanks.
Yeah. It doesn't affect the type of report. You're getting an unmodified or a clean report. At some point, if it gets so bad, or we've got hospitals that have shut down and whatnot, you can't get information. It could turn into a modified or even a disclaimer of opinion on a hospital. That's certainly not the issue here.
Good then. Thank you.
Mm-hmm.
So I appreciate kind of your opening context that I'm going to summarize. I live in ACFRs and financial statements. That's part of my day job. So I'm very familiar with audited financial statements for government entities. But kind of key takeaways, as our member Gallagher noted, is while we once again we have an obligation to publish that there is a no-bone concern, and we agree. We all share the same concerns. Two, the audit clearly reflects your ability to express a clean opinion based on quality and the competency of all of our staff who are doing and providing this information, providing it timely and providing it in a way that brings you trust and credibility. So it's a good outcome in that we have a clean, unmodified opinion reflective of the quality of the work being done behind the scenes. But we have a going concern because of largely environmental issues that are impacting all of healthcare and all rural hospitals like us.
You explain that. You explain that. Yeah, that explanation is you did a really good job on that. Most people believe that when you say the audit is clean or it's a good audit, that you had good results of operations, that you're doing well, and so on and so forth. An audit is just to make sure that the numbers are correct. Whether the numbers are good, bad, and indifferent, it's just that the numbers are correct, and we were able to get the information and put in, and everything was reported properly. Then, like you said, then that little blurb is that the numbers are all correct. Oh, and by the way, there's some challenges here with the financial position and the results of operations. So you got that right.
And then is, and I believe I might know the answer, but I'll just check this footnote 13 about subsequent events. We were talking earlier about QOF 9 under a normal cycle would have already been approved and in the 2025 audit as far as the revenue stream. It's still being held up by CMS, the federal government, for approval. At what level would that become a subsequent event, noting that QOF 9 is still languishing, it's still nearly a year on hold? Is it the moment when the CMS approves QOF 9, and then it would be a subsequent event that's happened, and then you'd be able to disclose it? Maybe I'm just asking, how would QOF 9 eventually trigger as a subsequent event discussion?
Well, that's a great question. There's a couple of things. If the payment came in prior to the audit being issued, that we were waiting on it, and finally, mid-March or whatever, the payment came in, it wouldn't be a subsequent event. We would just have, the hospital or the district would go ahead and just book would accrue it. So you'd book the income and you'd book the accrued receivable for the amount that you received anyway. And so that happens now and then. On the subsequent event side, if it got approved, if we've got information that substantiated that yes, they've been approved, payments are going out sometime here in the near future, blah blah blah, then we could certainly include that in the subsequent events. Has a little blurb in there explaining how much it'll be, the timing and whatnot, and the positive impact that'll have on the hospital, if you know what I mean.
And I appreciate staff and the inclusion of that in the MD&A discussion analysis, the discussion about QOF. I appreciate that. But thank you for entertaining that question. Just before going to the public, or any other questions, bring it back for final action. We'll pause to see if there are any questions from members of the public. None here. Let's bring it back for any final questions, deliberation, or action. No questions. I'll happily entertain. This is an action item requesting finance committees. Thank you. Finance board don't want to come out if they see them.
I think the forward word is.
Yeah. Move approval. Thank you.
Yes.
Dr. Gallagher?
Yes.
And Chair Bruce?
Yes.
Forward to the board.
So item number 4, an amendment to a loan agreement with the Santa Cruz County.
I'm going to go ahead and drop off, let you guys finish up, and I will join you again tomorrow for the board report. If anything else comes out of that, Jessica, you go ahead and get in touch with me, and that'd be fine. Have a great meeting. Thanks. Bye.
Thank you. So item number 4 is our last item on our committee's agenda to discussion a loan agreement with the Santa Cruz County to modify our existing loan agreement and to provide some financial resources to the hospital from the county. Before we move on, I just want to disclose that I am an employee of the Santa Cruz County. I work in the CEO's office. The nature of my employment does not trigger conflict. I believe I can stay in this conversation. I've not been involved in any discussions in this modification or loan agreement. It is ultimately with a department, the Health Services Agency, a department within the county that I'm not part of. So just wanted to put that on record that I've not been a party to or had any role in development or the modification or discussions regarding this loan agreement. So therefore, I feel comfortable staying in and being an unbiased, non-conflicted participant. With that, I'll turn it over to staff.
Okay. Yeah, so there's kind of 2 parts to this one. The first part is we've had a letter of initial transaction when the hospital and land was still owned by MPT was that there was the lease required a letter of credit for $2.6 million, plus there was $100,000 that went towards some of the early expenses related to that. So over the course of the time since then, I think that initial letter of credit was originally thought to be paid back in the first 6 months after opening the hospital, but in early 23, the county had recognized that we weren't going to be able to pay back $2.7 million at that point in time. At that time, we amended the agreement and set up a payment plan, and we made some payments towards that letter of credit. And then later in 24, we also had another negotiation with the county, and were able to work off some of that balance in a loan forgiveness with some of the work we did in the pediatric stabilization unit in the ER, while the county was building their new facility. So that left us with a balance of $700,000 that we still owe the county. We've had a payment schedule for that. We've reached out to them about the challenging cash times that we've had, especially with the way 2025 went for us. And so we got into another negotiation, which is this agreement, to be able to defer some of those payments. And so this part, the letter of credit part, is to push those payments out further and not even have them start back up until November of 26. Going to pay them over in 6-month periods, over 4, really 5 payments, but there's 4 payments that pay off $600,000 of it, and then the last payment pays off the last $100,000 of it. So the agreement actually goes into early 2028. As we were wrapping up kind of this structure for this piece of the work, we had also been in conversation about the line of credit that we have with West Coast County Bank. That's the $4 million line of credit that we've had for the last few years. And we're fully extended on that loan, and so right now, the only payments we're able to afford making is monthly interest payment. And so we came up in a discussion that the county would be willing to advance us some money for the next 6 months to make interest payments, because we've been having the conversation with the county to help them understand the impact of CLOP 9 being delayed so much, and how our struggles with cash flow have impacted our vendor payments and our abilities on the operational side, and that we're looking for ways to bridge funding until we get CLOP 9 funds. And so this was one way that the county felt that they could help us, was loaning us $40,000 a month over the next 6 months, so $40,000 to help cover those interest payments. And again, that payment would come due in starting later in the year, according to the schedule. And that was there. We'd split that over 2 payments. So we've kind of merged 2 different items in one amendment, and so I'm bringing it forward to the board to obtain approval to go ahead and execute on that agreement. And once our board has approved that, then Santa Cruz County will take it to their board of supervisors. Their plan is to take
Conclude your presentation. Thank you. Questions from board members?
I'm a newbie here too. This is sort of, let me see if I understand. County put up this letter of credit for that didn't get taken care of in the sale. It's not like the county got their money
demonstrate that I wasn't involved. So let me ask a bigger question. Was there a moment with the county that a larger loan, their discussion of the larger loan opportunities or options, and maybe you weren't privy to that, but how did we arrive at the Q40? I mean, cash flow is dire need, and I appreciate that. Feels like the direct line was the interest on the debt. Was there any willingness, or is there any opportunities that we might still explore with additional financing with the county?
Well, I would say we're in kind of constant communication with the county. They've been good partners to us as we've been working to try to identify various funding sources, ways to bridge the gap in Block 9. So I think this was an initial idea, concept that seemed easier to implement and fairly quickly.
And I recognize myself and my fellow finance committee member, on a small board of 5 people, we have a lot of other roles on the board, and 2 of us are on an ad hoc that are playing in the space too, but I just want to get an update on the nature of these conversations. I do acknowledge and I appreciate that the county doesn't appear to be applying an interest rate to any of the financing. That's a thank you to the county for not assessing the interest rate on that West Coast community line, the net rate based on reaching the age of 9%. So I appreciate that the county provided this free. No other questions? So our action is just to receive and forward to the board. For other questions, I'll turn to the members of the public. If there's any questions or comments from the public or any questions.
No hands on one.
None here. It was anticlimactic. I think we're done. This was a big meeting, a lot of good news, a lot of heavy topics. I appreciate, as always, you have an impressively quality team here. I'm proud to serve on this committee and to see the continual quality and trust in the numbers is doubted. There's never been a moment where I had to second guess. For candor and the level of professionalism, and your willingness to not hide the bad news, like some other government agencies, not my present employer included, of course, but we've all been around in these moments of high stress. It's really easy in a public setting to hide the bad news. And you guys have been very candid up front, so I just appreciate how we have these conversations. Certainly the quality of the work. With that, we are adjourned at 3:50.